All righty. So we are going to do integumentary system tonight. Well, let's just kind of jump in and start working on CPTs. So number one, Joe has a terrible problem with an ingrown toenail. He goes to the podiatrist to have a nail permanently removed along with the nail matrix. So let's do this one with the index and then we'll do process of elimination with some of the others that have multiple codes. So for this one, our main term that we are going to look up is going to be removal because that's our procedure that we're doing. We are removing the toenail. So we will do main term removal in the alphabetic index. Like I said, this one, we're just getting a little bit more comfortable with the index. Moving forward, like in some of the other questions that have multiple codes and things like that in the options, then at that point we'll start to do process of elimination. So we'll do removal, and then we are removing. What are we removing? What's the body part that we're removing? We are removing a nail. Yep. So then that sends us to 11730 through 11732 and then 11750. So let's find our 11730, 11732. So 11730 and 32 are the same family. So it's got the parent code and then an indented code. So they are both a avulsion of a nail plate, partial or complete, simple. So in this instance, we're not doing an avulsion. We are actually permanently removing. So we're going to skip the 11730 and 11732. And then let's go look at that 11750. That is the excision of nail and nail matrix, partial or complete. And then it's for an ingrown or deformed nail or permanent removal. So we are permanently removing, and then we're also removing the nail matrix. Somebody said in the chat, I found it easier to jump to the table of contents at the beginning of the chapter. I mean, yeah, absolutely. Sometimes, I mean, with the integumentary system, that probably is going to be a little bit easier. But whenever we're talking about, like in later sections, then where you have a ton, of different sections, then it might be easier to do the index. But yeah, if you feel like you can go to the um the table of contents at the beginning, then yeah, absolutely. Okay. So there's another question. Definition of the avulsion. So an avulsion is just going to be where we are removing some or all of the nail plate, but we're not taking the matrix out. So yeah, our answer is going to be B for the 11750. Okay. Any questions on that one? That one's pretty straightforward, just as long as we know the definition of removal versus avulsion. Yep. Okay. Number two. So we'll use process of elimination for this one. What CPT codes are reported for the destruction of 16 premalignant lesions and then 10 benign lesions using cryosurgery? So we have 17000 and 2. So let's go straight to that because we are going to either confirm 2 or rule out 2, either way. So we'll go to the 17,000. 17,000 is destruction, whether it be laser surgery, electrosurgery, cryosurgery, chemosurgery, or surgical curettement of pre-malignant lesions. And it's for the first lesion. So do we want to use 17,000? One of them would be 17004 because there's 16. Correct. Yep. So that's where, okay. So yeah, the 17,000, yes, is for premalignant lesions. 17,003 is for the second through the 14 lesions. But if we have 15 or more, which in this instance we have 16, right? So that gives us 15 or more. Then instead of reporting 17000 and 17003, we should only report a single unit of 17004. Does that make sense to everybody? So 17000, you don't want to necessarily just stop at that and just read that and say, okay, like this is what we're going to do, right? We want to kind of keep looking, especially whenever that one is just for the first lesion and we have multiple. We want to see what our add-on code is going to be for the additional. And then in this instance, we would not use the primary and add-on code. We would just use the 17004. That makes sense. So since we've got the 17004, we know the 17000 is not it, right? We have 17004 here, but this is not it. So we know our answer is D. Okay. Any questions on that one? That one's a little tricky. Xenia. So yeah, don't add them, but use the code that includes all of them. Yep. So if we only had 12 premalignant lesions, then we would have used 17000 and 003. But in this instance, because we had more than 14, we're only going to use the single destruction that is 15 or more. We don't need a primary code with it. I know this one is a little sneaky. So that's why I always try to make sure to go over this one so that you don't just stop at the 17,000 and then rule out B and D. And then we're kind of stuck and we're confused when really we've ruled out. Brittany, we're not using, the 17110 is going to be for the 10 benign lesions. So you have the 16 premalignant is the 17004. And then the 17110, if you look at that code description, that is for the destruction, again, laser, electro, cryo, chemosurgery, or surgical curetment of a benign lesion other than a skin tag up to 14. So Xenia, if you had 12 lesions, then it would be 17000 and then 11 units of 17003. Because you're going to use each of the additional up to 12 in addition to the first lesion. So basically in this one, it should always be the total number of lesions minus 1, and that's how many units of the 17003 you should report. Okay. All right. Number 3, the patient is here for a follow-up of a keloid excised from his neck in November of last year. He believes that it's coming back. He does have a recurrence of the keloid on the upper portion of the scar. Because the keloid is still small, options of an injection or radiation to the area were discussed. It was agreed that our next course should be Kenalog injection, and the risks associated with the procedure were discussed with the patient. Informed consent was obtained. The area was infiltrated with 1.5 cc's of medication, and this was a mixture of 1 cc of Kenalog 10 and a half of a cc of 1% lidocaine with epinephrine. So since we're in CPT, let's use our CPT to rule it out. So we've got two that have 11,900 and then two that are different codes. Let's go to 11,900. 11,900 code description is an injection intralesional up to and including 7 lesions. So do we think we should use that? Or if you're not sure, because this one is a little wonky, right? Too. So if we look at 11951 and 11950, those are for a subcutaneous injection of a filling material. So a filling material is going to be something that plumps up whatever you're injecting it into, right? So think about your lip fillers, cheek fillers, all of that kind of stuff, right? In this case, they have a keloid and they're trying to dissolve it, right? Because the keloid is still small, then we are going to try to get rid of it. So we don't want to use the ones that will indicate that it is a filling material, right? So we're just injecting a medication. And then let's go to our HCPCS manual. So that way we're getting used to looking at HCPCS codes. And let's go look at J3300 versus J3301. So J3300 is an injection of the triamcinolone acetonide, preservative free, 1 milligram. And then J3301 is an injection of that triamcinolone acetonide, not otherwise specified, 10 milligrams. So we should use the J30. Hang on. Sorry, I forgot to highlight things. We should use the J3301 because they did not specify that it was preservative free. And we did 1 cc. So that's going to be our J3301. And then in this case, we do not have to go to our ICD-10 at all. And so we've got our answer for number 3. Okay. Any questions on that one? Okay. Number 4, we've got patient presents to the physician for removal of squamous cell carcinoma of the right cheek. After the area is prepped and draped in sterile fashion, the surgeon measured the lesion and documented the size of the lesion is 2.3 centimeters at its largest diameter. Additionally, the physician took margins of 2 millimeters on each side of the lesion, and then your single layered closure is performed. The patient tolerated the procedure well. So looking at it from a process of elimination standpoint, we have 2 that have 11643. So let's go look at that. 11643 is an excision of a malignant lesion, including margins on the face, ears, eyelids, nose, and lips. And the excess diameter is 2.1 to 3.0. So we have the size of the lesion is 2.3 centimeters. And then we have margins of 2 millimeters on each side. So what is our total diameter of the lesion? 2.3 centimeters plus 2 millimeters on each side. So if we have 2.3 centimeters, 1 millimeter is 0.01, sorry, zero point 0.1 centimeters. And we've got that on each side. So technically we're going to add 0.2 centimeters for the margin. Yep. So that's going to give us 2.5 centimeters. So 1 millimeter is 0.1 centimeter. So they're testing you to see if you're going to add 2 to the 2.3 or if you're going to convert that correctly. So just keep that in mind. So we've got 2.3 plus 0.2. So our total diameter or the total excise diameter is 2.5, which is going to fall in that 11643. Okay. And then we need to decide, should we report that single layered closure separately? Or is it included in the excision? When in doubt, go to your guidelines. Yep, it's included. When would we code it separately? What type of closure should we report separately? Amanda, yes, you're right. Sorry. It is 0.2 on each side, so we're adding 0.4. Sorry. So that's going to be 2.7. Thank you, Amanda, for pointing that out. Yep, when it's an intermediate or complex closure. Yep, so anything other than a simple closure can be reported. Simple closure is included. Anything else can be reported separately. Yep. Okay. Any questions on that one? Okay. And again, Amanda, thanks for pointing out that I only did 0.2 total instead of it should have been 0.4. I was thinking it said 0.1 on each side. Or it said 1 millimeter on each side, not 2 millimeters total. Okay. Number 5. Meredith has breast cancer on the left side, diagnosed by an excisional biopsy that was performed last week. Today, she is having a radical mastectomy, urban type, and then concurrently a single pedicle tram flap reconstruction with supercharging. So we have 3 that have 19368, and then everything else is different. So let's go look at the 19368. That's at least going to help us somewhat narrow it down. So 19368 is going to be breast reconstruction with single pedicled transverse rectus abdominis myocutaneous, also known as a tram flap, requiring separate microvascular anastomosis with supercharging. So the 19368 is good, right? We know we need that one. Now, so that's our single pedicle tram flap. So now we need to find our radical mastectomy code. So we've just got to decide, is it going to be 19305, 06, or 02? So which one of those should we use for a radical mastectomy urban type? Sorry, I should have highlighted that one as well. Yep. 19306 is going to be our radical mastectomy urban type. And then again, we just have to make sure that we have our correct modifiers. And then we're going to use the 51 on the lower RVU. It's a 51 instead of a 59 because it's the same area that we did the mastectomy, the urban type mastectomy. And then we also did that tram flap reconstruction in the same session. Okay. Any questions on that one? Good job, Terry. Terry says she did it and she was correct. So good job. I'm going to move this down to the next line. Oh, not that way. the next page, so it's all on one. Okay. Number 6. Patient is an 81-year-old male with a biopsy proven basal cell carcinoma of the posterior neck just near his hairline. Additionally, the patient had 2 other areas of concern on his cheek. Informed consent was obtained, and the areas were prepped and draped in the usual sterile fashion. Attention was directed to the basal cell carcinoma of the neck, and I excised the lesion measuring 2.6 centimeters as drawn down to the subcutaneous fat. With extensive undermining of the wound, I closed it in layers using 4-0 monopril, 5-0 proline, and 6-0 proline, and the wound measured 4.5 centimeters. Attention was then directed to the other 2 suspicious lesions on the cheek. After administering local anesthesia, I proceeded to take a 3 millimeter punch biopsy of each lesion and was able to close with 5-0 proline. The patient tolerated the procedures well. Pathology later showed the basal cell carcinoma was completely removed, and the biopsies indicated actinic keratosis. So the easiest way to do this, you have 2 that have 13132. Let's go take a look at that and see if that matches or if we're going to rule those out. So 13132 is a repair complex on the forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands, or feet. And then it's 2.6 centimeters to 7.5 centimeters. So our complex repairs are going to be here. So we've got 4.5 centimeters for the complex repairs. Okay. So that falls between 2.6 and 7.5. And then we've got 11623 is in both. So I'm just going to skip that one for now. Then you're going to have 11104 and 11440. Cross those out because my eyes are. So let's go look at the 11104 versus the 11440. So 11104 is a punch biopsy of skin, including simple closure when performed, single lesion. And then 11440 is excision, other benign lesion, including margins, except for skin tags, face, ears, eyelids, nose, lips, mucous membrane. And then excise diameter is 0.5 centimeters. Okay. So, yep, Zinnia says 11104. So the punch biopsy. Hang on? Did I read the right code just a second ago? My brain. Yeah, 11104 is our punch biopsy of the skin. So we did 2 punch biopsies, right? We did a punch biopsy of each lesion, and there were 2, right? So we're going to use 11440. No, sorry. We're going to use 11409, not 409. 11104. My poor brain cannot read numbers tonight. So we're going to do 11104 and then the 11105 for the second. Okay. Now, why are we not putting a 59 or a 51 on 11105? So why is there not a modifier here? Yep, Emma's right. It's an add-on code. Yep. Perfect. 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 Okay. Any questions on that one? Sorry, my brain was not wanting to make sense of the numbers. Sorry if I confused anybody on, on trying to read those out loud. I was getting stuck on my eyes were focusing on that 9 for some reason. Yep, add-on codes, no modifiers. Perfect. Okay. Number 7. We have patient presents to the emergency department with multiple lacerations from a knife fight at the local bar. After examination, it was determined that these lacerations could be closed using local anesthesia. The areas were prepped and draped in the usual sterile fashion. Surgeon documented the following closures. We have 7.6 centimeters simple closure of the right forearm, 5.7 centimeter intermediate closure of the upper right arm, 4.7 centimeter complex closure of the right neck, and a 10.3 intermediate closure of the upper chest. There's got a lot going on. So for this one, we have 3 that have 13132. We have 2 that have 12035. So this could potentially rule out faster than looking at the 13132. Okay. So let's go look at 12035. Let's see what our code description is for that. So that is repair intermediate wounds of scalp, axilla, trunk, and or extremities. And then it's 3.5. So it should be 12.6 centimeters to 20 centimeters. So we're looking for intermediate. So we've got an intermediate closure here, which is 5.7 centimeters on the right arm. And then we have a 10.3 intermediate on the upper chest. So let's make sure our anatomic groupings match. So scalp, axilla, trunk, and or extremities. So we've got one extremity, and then our upper chest is going to be considered our trunk. So we can add these 2 together. So we're going to have a total of 16 centimeters, right? So 10.3 plus 5.7. So we know the 12035 is our code for the intermediate closures. Okay. Now we can go, because the 12004 is the same. Now we can go decide, is it 13132 or is it 13152? Yeah, Melissa, I'll explain that here in just a second. So 13132 is a repair complex of the forehead, cheeks, chin, mouth, neck, axilla, genitalia, hands or feet, 2.6 to 7.5. And then 13152 is a repair complex of the eyelid, nose, ear, and or lips. So we're looking at the complex. So on the neck, that's going to fall underneath the 13132. So other than the modifier question, any questions on that one? So while I'm answering the modifier question, if you have any questions, then put them in the chat. So Melissa, the reason we are not going to put a RT modifier or any anatomic modifiers when you're in the skin, then if we think about the integumentary system as a whole, it's a full body type anatomic location, right? You'll have certain areas, but they're not as really, you don't have 2 skins, right? You might have 2 arms, but you don't have 2 skins. So the skin as a whole is going to be more like a full body type thing versus if we have a fracture on the left arm, we have 2, let's say left tibia. Okay. So we have 2 tibias, one in the left, one in the right. So that's when our anatomic modifiers is if we have 2 and we can identify easily with a modifier left or right. If we were to put an LT, or I'm sorry, if we were to put an RT on this one, for the 12035. 12035 has scalp, axilla, trunk, and or extremities. So if we were to put in RT, that's not going to tell us exactly where it is. Does that kind of make sense? Okay, yeah, I know. Integumentary system, you really won't use anatomic modifiers too much unless you are identifying a specific toenail or fingernail, or if we're talking about the breast, then it would be the LTRT. But other than that, most of your integumentary codes should not have anatomic modifiers appended to them. I know that's kind of a weird, a lot of people tend to have that exact same question. So don't feel bad that your brain did not want to make sense of that. It's a very common question when it comes to the integumentary system. Okay. Any other questions that you guys can think of on this one? Okay. Number 8, patient is here because the cyst in her arm has become to a head or has come to a head and is still painful enough, even though she's been on antibiotics for a week. I've offered to drain it for her, and after obtaining consent, we infiltrated the area with 1 cc of 1% lidocaine with epinephrine, prepped the area with betadine, and incised and opened the cyst and the relaxed skin tension lines of her chest, and then removed the cystic material. There was no obvious purulent, and we are going to have her clean this with a Q-tip. We'll let it heal on its own and eventually excise it. We'll have her come back in a week from Tuesday to reschedule the surgery. So here, we don't even have, there's no 2 options that have the same codes, right? All of our CPT codes are different. All of our ICD-10s are different. However, we have 2 that are very close to each other. We have 160 and 161. So since those are so close to each other, let's go look at those. So 160 is an incision and drainage of an abscess, which is what we did, right? And then it's simple or single. And then 161 is complicated or multiple. So we drained, we did the incision and drainage. And then is it a simple, or do you think we would consider this complicated? Yep. Yep. So it's simple. So without looking anything else up, we've got our answer. So again, this one we didn't even have to touch ICD-10. Oh, I lied. We do have 2 that have the same L72.9, and then we would have had to have done the same thing. We would have had to decide between 60 and 61. Okay. Any questions on that one? Okay. Number 9, localization wire placement or localization wire placement in the lower outer aspect of the right breast was performed by a radiologist the day prior to this procedure. During the operative session, the surgeon created an incision through the wire rack, and then the wire track was followed down to its entrance into the breast tissue. A nodule of breast tissue was noted immediately adjacent to the wire. This entire area was excised by sharp dissection, sent to pathology, and returned as a benign lesion. Bleeders were cauterized and subcutaneous tissue was closed with 3O Vicryl. Skin edges were approximated with 4O subcuticular sutures, and then adhesive strips were applied. The patient left the operating room in satisfactory condition. So we have 2 that have 19125. So more than likely, that's going to be the code that we need. But let's just go look at the 19125 and see what it is. The 19125 is excision of breast lesion identified by preoperative placement of radiological marker, open, single lesion. So that's what we did, right? We excised the area by sharp dissection, and then it was next to that wire that they placed the previous day, right? So we're going to use our 19125. Now, the main question is, do we code the 19285? The 19285 is the placement of the breast localization device. So are we reporting the 19285? Right. No, I've got a couple people saying that it is letter A. Some people are saying no. Right. So we are not going to report the 19285 because that wire placement was done yesterday, right? So this surgeon is only reporting for the excision itself. Yep, good job. Okay. Any questions? Okay. Number 10, we have a 56-year-old pro golfer that's having Mohs micrographic surgery for skin cancer on his forehead. The surgeon performs the surgery with two stages. The first stage includes 4 tissue blocks, and then the second stage includes 6 tissue blocks. So, what are the codes for both stages? So, we have 3 with 17311, and then we've got 2 with 17312. So let's go look at the 17311 and the 17312. So your 17311 is your Mohs micrographic surgery, including removal of all gross tumor, surgical excision of tissue specimens, mapping, color coding of specimens, microscopic examination of specimens by the surgeon, and the histopathologic preparation, including routine staining on the head, neck, hands, feet, genitalia, or any location with surgery directly involving a muscle, cartilage, bone, tendon, major nerves, or vessels. Okay. And then the 17311 is the first stage up to 5 tissue blocks. So our first stage, we have 4 tissue blocks. So we know we need the 17311. And then the 17312 is our second stage up to 5 tissue blocks. So we did have a second stage, and it includes 6 tissue blocks. So we know we need the 17312, right? Now, 17315 is for your Mohs micrographic technique. I'm not going to read all of that again because that's really long. Each additional block after the first 5 tissue blocks, any stage. So the 17315 is going to report that 6th tissue block because the first 17312 for the second stage includes 5 tissue blocks, right? We did a total of 6, so we need to report 1 unit of the 17315 so that we can report the 6th day or the 6th block within that second stage. Does that make sense? No, Jenny, you're totally fine, Jenny. Trust me, I know. Your eyes will play tricks on you for sure. So, the stages are going to be the pieces of tissue that come directly out of the patient. And then a block is going to be each time that that stage is sliced and put into underneath the microscope. So there's two separate components that you have to have with Mohs, stages and blocks. So in this scenario, we have two stages. So we have to have the 17311 and the 17312. And then we need that 17315 for that sixth tissue block on that second stage. That makes sense? Any questions? I know most can get a little confusing and a little tricky. Okay. Um, yeah, absolutely, Amanda. I'm happy that I can help. I don't think I've seen you on here before, but if I have, sorry. But yeah, I'm absolutely happy. I'm glad that we were able to continue on after our mishap last week. But like I said, moving on next week, we'll have like a poll option for it. No Zinnia. So with 173 or with letter A, okay. So the reason that we're not going to use letter A, so I mean, yes, technically 17315 is correct, but we have to have the 17312 to indicate that second stage. So if we were to report 17311 and 17315, we would underpay our provider because they're not getting paid for the second stage where they took that specimen directly out of the patient. Yep. Yep. So in this instance, because the first stage did not have over 5 tissue blocks, it wouldn't be appropriate to report 17315 with just 17311. We would need the second stage in order to report the sixth block on the second stage. Now, had they said the first stage had 6 tissue blocks and that was all they did, then A would be correct. But because we had a second stage, yeah. So, Brittany, if there were 3 stages, then we would have an additional unit of 17312. So, if we had a third stage that had 4 tissue blocks, it would be 17311, 17312 times 2, because we would just have second stage, third stage. And then we would just have a 17315 for the second stage that had the 6 blocks. Mohs is hard. It took me forever to figure out how to wrap my brain around Mohs. I even have coworkers to this day that still do not get Mohs. And it's just because it is a complex, it's a very complex topic for sure. So just make sure if they test you on Mohs, you're reporting the number of stages. And then if you have any stages over 5, that's when you're going to report the 17315. So you want to make sure, just as equally important as that extra block, we have to make sure we have that additional stage. And then there was one other thing. Oh, there was one up here. Hang on, let me scroll up. Let me figure out which one it was. That my eyes always play a trick on me. Like with this one here that we did, you see how they are transposing some numbers to see if your brain is paying attention to them. So they will give you some options that are going to be very, very, very similar. They may have given you, instead of 174, I'm sorry, 11440, they may have given you 11140 or 11004, right? So they're going to see if you are paying attention to the detail and you're not just seeing the ones and fours and clicking whatever, the first one is that you'll see. So it's equally as important to make sure that you're looking at all of the codes and all of the options to make sure that you're not accidentally ruling something out or including something that you shouldn't, because there's going to be some that are very, very similar. And my poor eyes, especially if I've been doing a whole lot that day, my poor eyes will mix them together and not realize that they're different. So it's easy to do. So if that does happen, don't feel bad. Just just take a half a second. So Destiny says questions on legions. If it doesn't give you margins, do you just code for that diameter that they give you? Yes. And then you add the diameters together if they are the same anatomic location and complexity. No. For lesions, it is per lesion. So if you have three lesions that you're doing an excision on, then you are going to have three separate excision codes. The only things that you add together are going to be your repairs, and then potentially on your destructions where your code is going to indicate a range. So when you're talking about lesions, then you're going to do it per lesion that is XI. And then Kristen, yeah, I know. Anytime I take one, I have to do it first thing in the morning because the longer that I go during the day, the more fried my brain gets, and I miss the tiny little things. Yeah. Yep. Oh, you're welcome, Destiny. I'm glad that helped. Yeah. So I in my book prep that I sell, on the lesion section, and I'm trying to get to it. Yeah, I have next to each one, each individual one, each lesion. So that way it's another reminder that don't add these together. If I have three lesions, I should have three codes. Yeah, integumentary is kind of hard because some of them, like you said, we'll add them together. Some of them will do them separately. So make sure that you just have little notes in there for the ones that you're supposed to add together, and then the ones that you're supposed to have per legion or separately. You're welcome, Kristen. I'm glad they're helping. All right. Yes, Brittany, they usually will run an hour unless like we get done with questions early and there's just no or scenarios early and there's just no questions. I'm not just gonna sit here and just make you guys listen to me chat. But yeah, usually they will run an hour. Sometimes they might even run a little bit over, depending on like the scenarios and before when we would have conversation. Unfortunately, like I said, I'm gonna try to do a couple weeks like this, kind of hopefully not have the people that kind of showed up last week. And it wasn't a student. Like I want to make that clear. Like it wasn't a student at all that ruined it for everybody. It was just some random person that got the link to the meeting and came in and took over screen share and started coming off of mute and saying very inappropriate things. So I just want to make that clear. Like that, it was not a student. So I want to make sure that we just don't have that show up again. Kristen, can you tell us what next week's topic is? The link that I am going to put in the chat that I just put in there. Save this link. Okay, this is the Google Doc. On that Google Doc, and I'm going to share the screen so everybody can kind of see it all at the same time. On that Google document, okay, here is our schedule. So today is the 5th. We just went over integumentary. And then this has the link to any of the questions that we're going to go over. Anytime the questions are changed or updated, then the link will be updated too. So next week, we're going to go over 20,000 series. And then if you don't have the YouTube channel bookmarked, then the link will show up here. So as soon as as soon as I get it processed, then I'll put the link in here and it'll be in here tomorrow. But if you save this and if you like, if for some reason like you're not able to join for a couple of weeks and you're like, hey, what are we doing for this week? Because I've missed a couple of weeks and I don't know what she said and all of that kind of stuff. This Google Doc is always going to be up to date. So anytime there is any changes to it, then this will. So like if we have to skip it for whatever reason, then I'll just kind of shift everything down type thing. So this is a link that you guys can save. Yep, absolutely. Destiny, yeah, this one is going to be posted as soon as it gets done processing. If it doesn't process in time tonight, for me to get it uploaded into YouTube, then I'll get it into YouTube first thing in the morning. Okay. All right, guys. Well, let me stop the recording here real quick.